looking forward to this discussion. If you, as an audience member, have a hard question, we want to hear those.
Well, they are answering all my answers, actually.
Yes. Oh, yeah. He actually had questions for you. What we want to do is talk a little bit about your work, and then really interact with you and hear where you're at. Like, a lot of what's going on in the modern healthcare world is that we need more interaction.
Sure.
So I appreciate you coming here and being willing to be that representative. I'd love to hear about your work. Tell us about the populations that you work with.
Sure. All right. Happy New Year, everyone, and healthy one. My name is Jeet Barmecha, and I am a practicing hospitalist, part-time, and my full-time role has changed since last 8 months. I used to be CMIO, then CIO, and now they added digital strategy, and we'll talk more about what that
what that means.
Yeah. And sounds very sexy, but a lot of work. So yeah, I mean, I work in the Bronx, which serves primarily underserved population and socio-economic disadvantaged population. And in terms of statistics, it's not a good statistics when it comes to the Bronx. I think we are one of the most unhealthiest county in the state of New York. I think 59 or 60 out of 60. What that means is a lot of opportunities, obviously, to move the needle. In terms of population, about 85 to 90% are on public program, whether it is Medicaid or dual and then we have 10% since we are trauma centers, so we do get some commercial when they get hit on I-95 or I-87 when the trauma comes to us. But I'm very happy to be here. I see a lot of familiar faces after I think 3 or 4 years actually.
Yeah.
The only disadvantage of these kind of meetings is you can't put me on mute, and I can see you everyone, so you can't switch off your video too. So that's an exciting part.
Yeah, it's an exercise in sitting still.
Yeah.
I feel like I'm like, oh, I forgot. People can sit still for a long time.
Yeah.
I want to hear more about what you're saying with strategy.
Yeah.
Like, because sometimes in healthcare, you have like two camps. The people like strategy, that's a fake title. And the people who are like strategy, that's math. Like, so what is it?
I think is the evolution in healthcare. The way I see it, business strategy has become more and more digital actually. So again, that's my own opinion, the way I see through my lens. And whether this digital transformation or acceleration is within the organization or outside the organization. So I do a lot of work within the organization as well as outside the organization. And yes, I'm on the table with the board or C-suite, talk about overall business strategy and how my role fits into those business strategy, whether it is patient care or transformation or practice merger or acquisitions or and if you look at other healthcare or health systems, I think these are all aligned. Making sure that the patients or the community have better access.
Yes.
And that's how now the geographic surface or the service area, the definition has changed. And it has changed in last 3 years.
Where you're delivering care? Or
correct. I mean, with the virtual care now, bricks and mortars are no longer that. And even from provider to provider consultation, things have changed. I mean, I think across global, not only here in the US.
Yeah,
so,
we've seen huge transformation in even the makeup of cities and how things change. I'd love to kind of break that down for people.
Mm-hmm.
Let's start with the investment side. Like, how do you make decisions? I've spoken to some CIOs and in well-being, especially, they're like, how do we justify this program? Like, how do you make those decisions?
So I oversee also clinical engineering or biomedical engineering. So medical devices. I think after utility, I'm the most expensive, or my departments have most expense in the entire institution.
Shout out to expensive departments.
Yeah. I mean, if you combine both clinical engineering and IT, telecom, data analytics, so on one side we have more than 10,000 medical devices we manage, and on the other side, desktops, phones, headphones, you name it. 60% is real job, 40% is politics. I'll be very honest.
That's
because
in writing.
You can't make everyone happy, but I'm very blessed with my team, and I make sure that the patient care areas are in terms of triaging, right? Patient care area supersedes any request, except when the CEO calls that his iPad is not connecting to whatever. Other than that,
that's a different panel.
Correct. But they all go through the same ticketing or whatever system. Patient care area absolutely takes the preference. And then comes the individual offices and so forth. So, I mean, we do triage like this, and many a times I do make the decision, but sometimes I influence the decisions. Because I interface with almost every department and corner of my health system, whether it is operation, finance, HR, lab, radiology, you name it. I mean, we are there. If not biomed, it will be IT. So it's very challenging, but again, it's very gratifying too at the end of the day.
Yeah.
We compiled a book. We wrote a book actually, which was just published last year on our work during pandemic surge.
Oh, really?
Yes. It's available on Amazon or Springer. Basically, we took all the department leaders and what we did. So it's kind of a toolkit for small to mid-sized health system serving underserved population, how we overcame. And again, when you read, most of the health system have similar stories.
Right. Will you summarize your book for us in 2 minutes? Let's say
people. No, read only the chapter which I wrote. So
what was that? So it's a book. So we could probably go over it 5 minutes, maybe. What does that mean? And I'm really interested in this, like the digital world. So if you're connecting to all those aspects of the hospital, and your patients are largely not coming to the hospitals anymore, what does that mean for you?
I would say now they are coming. I mean, obviously, face-to-face has to be there for certain services. Telemedicine or telehealth cannot be panacea for all the healthcare activities. You still need to come for diagnostics or therapeutics or procedure. So people are coming back. We do have wait time for certain procedural areas, elective ones. But in terms of efficiency, we are always constantly looking for ways to become more efficient in terms of either scheduling or rescheduling or follow-ups or through their patient journey. In nutshell, that is all the patient-facing digital acceleration. I would not call it transformation because we are not there yet. We are all in my opinion, we are all in the acceleration phase. And COVID had really brought to the surface. It was a myth that in the Bronx, people don't use smartphones. Almost 95% of US population do have cell phones. They may not be smart ones, but they do have phones. And again, majority of our patients do have smartphones, and they would love to use smartphones. So again, it was myth, which people have,
What are common what are other common things that you hear that are misunderstandings?
And again, for certain non-procedural specialty, we were blown away or surprised, and they align with the data across the country. behavioral health. We never thought that people are going to use video consultation for behavioral health so much. And it is still number one, whether it is audio or video. I think behavioral health or psychiatry or substance use disorder, the virtual care is number one. And then my background is internal medicine, and I was pleasantly surprised that the certain specialty within internal medicine still skyrocketing video consultation, especially in rheumatology and endocrinology. So those were some of the surprises. Again, we didn't have appropriate tools to integrate within the EMR. It took a while for us to get to adoption from the provider side as well as from the patient side, especially onboarding. We had several challenges with our. I don't want to name any vendor here.
But we'll have a list printed online.
But things. But looking back, I think it has become plateaued. And if you look at the statistics, the telemedicine piece of telehealth is sort of plateaued or even going down, especially for primary care and all. Because they have the same experience. They used to wait in the waiting room. Now they're waiting in the digital door or whatever digital waiting room. I think in next couple of years, there will be more acceleration on the, I like to call it remote patient management rather than remote patient monitoring. We are not monitoring anymore those devices. We are going to manage these patients. And some of the good demonstrations which have come out, especially on the Medicare Advantage population on the hospital at home, I think there is, if I have to put money somewhere, it will be on the virtual care, especially on the remote patient management, whether it is on the healthy lifestyle or preventative medicine or not so sick people who require critical care and an overall population health management set. So that will, the whole telehealth landscape is going to transform, in my opinion, on the virtual care.
I think it will be more
on the chronic disease management. As I said, it will move from RPM to remote patient monitoring to management side.
That would be amazing if people called you when you needed a refill.
And at the same time, there will be a lot of, so this is more about care innovations. And if you look at the other side of the coin, data innovation, more and more meaningful information will be coming to the screen so that we can get informed decision, whether it is on the population side or also on the individual side. I thought there was one speaker on ChatGPT, no?
Yeah, that's tomorrow.
That is going to transform some.
I do have a question. Once, a few years ago, I talked to a company who did stuff in the Medicare space, and I was asking, like, what are you doing for Medicaid? And they said it was hard to show value for chronic care management for Medicaid patients. Let's talk about that.
Not in New York, or maybe where you have managed Medicare. New York, as you know, majority of the Medicaid population is under managed care in some or the other.
Describe that.
So majority or almost every Medicaid population in New York State are part of a managed care organization.
Okay.
And especially in New York, Greater New York or New York City, if you look at the health plans, especially Health First or Fidelis and all, they are very unique because these are run by providers. So they are kind of payviders, which is the new terminology people are using for CVS Health and all. But New York already had payviders in the past or continuing. So
before it was trendy.
Yeah. So managing, but on the health system side, we are still on fee-for-service world. They talk about value-based care when the district came, but when we go into the boardroom, when we talk about P&L, it is all about fee-for-service. It is all about utilization. It is all about length of stay. So I think that paradigm is also going to change in next 3 years or 5 years, in my opinion. So we are looking at the revenue cycle system how that will align with the value-based care. Now, coming back to the Medicaid population in New York and also in the other states where this delivery system reform incentive payment program or DSRIP, whether it is in Texas or North Carolina, they all have similar theme, but they were not all the same. And in New York, this is pre-COVID actually. The whole goal was to reduce preventable admissions and ED visits. Mm-hmm. And it was a 5-year program. Within 3 years, they accomplished the goal. So they did reduce the preventable readmissions and ED utilization. So coming back to your question on the Medicaid population, any demonstration, Medicaid population is younger age group, by and large, mostly women and younger individuals, a lot of behavioral health issues and the social determinants of type of health issues. But it's like 10 or 90% rule, 10% of them usually utilize most of the cost. And if you can manage well those 90% and make them healthy, I think it's a win-win situation. So yeah, New York has a good, I would not say very good handle on all the care transformational activities outside the 4 walls, but it is getting there. I mean, there's one organization I would call out is the City Block. They primarily do some care transformational activities, making sure that the health equity is also addressed. Mm-hmm. And I think similar models are in different pockets of the country. And main thing is providing good access, reducing hospitalization, and making sure that whatever interventions are needed, whether it is therapeutics, virtually or in person, is delivered.
Yeah. So when you're saying chronic care management and like nudging towards healthy behaviors, what type of data are you using to make those decisions?
So we have some data.
Question, maybe.
No, we have some data. Again, we don't have data like digital twins, I mean, what data we have
They're not spying on you, so everyone can.
No, I mean, what data we have is whether it is in our EMR or what comes through the claims. Right. We don't have so much. If you want to get 100% data, you need to develop digital twins. I mean, we don't have housing data. We don't have what they eat. I mean, their behavior. So whatever data we have, I think we are trying our best utilizing virtual care navigators, making sure that they are coming or identifying care gaps based on the claims information for certain group of population, whether they are diabetics or elderly or whatever those are.
Yeah. So what successes have you had in your agenda or your goals?
So some of you may not be familiar with the district activities in New York. We were one of the, I think, 5th largest PPS, provider performance system. We were managing close to 400,000 Medicaid lives. And as I said, within 3 years, we accomplished our goal. We reduced the readmissions with intensive case management. We reduced the emergency ED utilization by making sure that appropriate signals from the noise were picked up and prevent hospitalization. But again, the COVID turned everything differently. But now we are working on District 2.0, which is more on the looking at the lens through health equity, or diversity, and value-based care.
What does that mean for what do you
taking
see
full
in the
risk.
next 6 months?
Well, it's a journey. I would not say it's only a 6 month. This will be a journey.
We're going to be done with health equity in 6 months.
No, what I'm not only on the health equity side, but also on the value-based care side. Again, it's a journey. Lot more have to be done on the prevention side.
Mhm.
Maybe initially there will be more utilization because people have not come to colonoscopy or eye exam or foot exam or whatever. But eventually, for the long run, I think it will balance out when you have decreased amputations or dialysis or something like
Absolutely.
that. I think the whole, whatever sexy term you come up with, value-based care, or I think the punchline is health outcomes. The outcomes, people need to be living more healthy. I mean, not necessarily longer, but healthy and longer. That is
Yes.
the health outcomes.
Because they want their quality of life to improve.
Correct.
You want
Correct.
health outcomes.
Yeah.
That's a good goal. What are your major barriers? Like, what if people were listening now? Like, what do they need to know about your work in the city?
I mean, our barriers have changed. I want to highlight a couple of them. One is obviously we serve very poor population, and money is never enough. We get almost 65 cents for every dollar of care we provide. So even for newborn deliveries, we are always at a loss. Every baby is born, we lose money actually. But again, that's our mission. We do. If we had the same patients with a better payer mix, it will always be in black. So, for example, if we get commercial rate for every inpatient or every encounter, obviously. So financial resources are scarce. Number two, lately, is the workforce. I mean, it's such a paradox that they are laying off from the tech companies. I was reading yesterday, almost 250,000 layoffs. We only read about Microsoft and Google and Amazon, but there are a whole host of other companies. But we have a very different challenge. We have so many positions which are getting unfilled. And I don't know, especially on the nursing and ancillary side. We didn't have so much attrition on the non-clinical areas or even in the operation areas. Mostly it was on the clinical side, and I'm sure there are some clinicians in the room, they can validate. Although we had at time travel nurses who could just fill in, but things are getting worse in my opinion, especially on the lab technicians, radiology technicians, echocardiogram. I mean, all those ancillary staffing is a huge challenge. I do not know whether it will get worse before it gets better, or because these workforce, it takes time to train someone to build those competency.
Right. Like you said, during the telemedicine thing, you had to train people how to use it.
That was easy, coming onto the screen and talking, and people were using WhatsApp or FaceTime. So it was relatively easy, but this one is skill. I mean, you have to develop those skills. At least in our health system, and I'm sure, I mean, I talk to so many of my colleagues, everywhere is the workforce issue. And as a physician, if you look at the statistics from the workforce from the physician side, by 2040, I think there will be a need of more than 150,000 physicians. So I do not know how many medical schools are going to open up in next 10 years. Yes, the advanced practitioners are kind of helping us. But again, at the end of the day, you need doctors and nurses and ancillary staff. So hopefully things will get better, but workforce is a huge challenge. Our retention strategies are not working. Prior to COVID, I mean, at least in my department, they were working 1 day per week. We were hybrid. So now we have like either 2 days or 3 days, depending on what their work is. That has been a good retention. In some areas, we have 100% virtual. But in clinical areas, you can't do everything virtual. You need nurses, you need CNAs, LPN, and somebody to feed those elderly or disabled or challenged patients. So, what I'm hearing, nobody wants to get into healthcare. Hopefully, these layoffs will, somebody will turn into healthcare and develop certain skills. And,
someone might be watching who's been laid off and wants to help.
Yeah.
Do you think digital tools help with that, or do you think that's sort of separate?
I think technology is only going to enable.
Yeah.
For me, people always comes first. That's why I love this kind of conference. Then your process and then technology. I mean, we need people. I'll be very honest with you. I was in India about 2 weeks ago for 2 weeks. It did not impact that much because I think it has become the most populous country in the world. So, but again, there are certain areas they are also having some challenges with the humans. Certain people don't want to do that kind of work, especially in the healthcare setting. So, and they're afraid. Or maybe just a COVID fog. I don't know. I mean,
I feel like we're supposed to give people hope.
I'm sorry?
I was about to open up for questions, but I feel like I have seen that as well. Like there's a lot of people leaving, and people aren't really quite sure how to fix that. From where you sit, what are you doing?
I think no, I don't think anyone has found a panacea of this workforce issue, because it's not only the number of people, but it's also the competency. You know,
Mm-hmm.
There are certain skill set you can learn virtually, but then there are certain skill set you need to see actual patient. Or I mean, sim lab is good, you know, for CPR and all, but you have to do it on an actual patient to make sure you are doing the right way. You know, you have to draw the blood to make sure you are getting into the right vein. Yes, you can have the technology to see where the veins are, but you still have to draw the blood and do the X-rays and MRIs. And so developing those skill sets through various channels. Maybe we have to look people from outside of healthcare, the traditional healthcare, how they can help. But yeah, I mean, as digital tools are there to enable, but you still need human, because at the end of the day, we are all treating human beings, you know.
Yeah. I want to thank you for your time. Yeah. So just thinking about where things are, and
All right, thank you, everyone.
thank you for the work.
And,